Video Conferencing Center. You can enter a conference ID followed by the pound sign at any time. You're now joining the conference. This call may be recorded.
Okay, so welcome to the learning curve. Those that are logged into the live meeting, first we would ask you to click on voice and video to mute your computer, which is the symbol that looks like a speaker on the right of the phone with the X. So you could just click on mute. And we have poll questions, if you could please answer them before we begin.
This is one of 4 polls interspersed throughout this talk.
Okay, we're going to go ahead and start. Is that okay, Judy?
Yep.
Okay. Welcome to the Learning Curve, a geriatrics professional development series. My name is Faye Francisco, and I'm coordinator of Geriatric Scholars Program at the GREC here in the Bronx. This is the second webinar in a 2-part series. The topic today is Managing Team Dynamics, and our speakers will be Drs. Judith Howe and Ronnie Chernoff. This is a series and sponsored by the Employee Education System in collaboration with the Consortium of the New York Geriatric Education Centers, the Arkansas Geriatric Education Center, and the Geriatric Scholars Program, which is funded by the VA Office of Rural Health. The presentation will last 45 minutes with Q&A at the end of the session. We will have time at the end of the presentation to ask any questions and for the speaker to answer. This session will end promptly at 4:05 Eastern Time. If you have any further questions for the presenter, please send them to the Geriatric Scholars Program Manager, Lauren Jones, at lauren.jones@va.gov, and she will forward them to the speakers. To receive CME, CEUs, and to complete your registration, you must contact your VISN satellite coordinator and request a registration evaluation form for this course. You can find your VISN satellite coordinator's name at http://va.www.ees.1rn.va.gov/1923. We could also send you that link if you would like to request it. Now, I'd like to introduce our speakers for today. Dr. Judith Howe is Professor, Brookdale Department of Geriatrics and Palliative Medicine, Mount Sinai School of Medicine, and Associate Director of Education and Evaluation, VISN 3 Geriatrics Research, Education and Clinical Center, GREC, based at the James J. Peter VA Medical Center. She also holds a secondary appointment in the Mount Sinai School of Medicine, Department of Preventative and Community Medicine, is the Director of the Consortium of New York Geriatric Centers, and is Director of the VISN 3 GREC Interprofessional Palliative Care Fellowship Program. Dr. Howe holds 2 master's degrees from Syracuse University, Sociology and Public Administration, and a PhD in Social Welfare Gerontology from Fordham University. She is co-founder and chair of the Board of Directors of Linkage House, housing for lower-income persons in New York City, which is funded by the Federal Department of Housing and Urban Development. Dr. Howe has received $5.5 million in grant awards. She has presented at numerous national meetings and has published widely in books and peer-reviewed journals such as Gerontology and Geriatrics Education, Journal of Social Work in End-of-Life and Palliative Care, and Journal of the American Geriatric Society. She has edited or co-edited 3 books on aging, geriatric mental health and emergency preparedness, older people and their caregivers across the spectrum of care, and ethical patient care, and is the editor-in-chief of Gerontology and Geriatrics Education, the official journal of the Association of Gerontology in Higher Education. Dr. Howe has been active in professional organizations, having served on many boards, including the Executive Committee of the Association of Gerontology in Higher Education, President of the State Society on Aging of New York, and President of the National Association of Geriatric Education Centers, National Association for Geriatric Education. She was a Department of Health and Human Services Primary Healthcare Policy Fellow and is a Fellow of the New York Academy of Medicine, Association for Gerontology in Higher Education, and the Gerontological Society of America. Dr. Ronnie Chernoff is the Associate Director for Education and Evaluation for the Geriatric Research, Education, and Clinical Center at the John McClellan Memorial Veterans Hospital in Little Rock, Arkansas. Director of Arkansas Geriatric Education Center, Professor, Geriatrics, College of Medicine, Professor, Health Education and Health Behavior, College of Public Health, Director of Education in the Donald W. Reynolds Center on Aging at the University of Arkansas for Medical Sciences. She received her BS in Nutrition from Cornell University in Ithaca, New York, and MS and MED in Nutrition for Columbia University in New York, and her PhD from the University of Pennsylvania in Philadelphia. Dr. Chernoff has been the recipient of over $7 million in grants and contracts. She has also been a prolific author and editor. She has edited 5 books and published 43 abstracts, 44 journal articles, and 110 other publications, including book chapters, invited reviews, and other articles. Her books include Health Promotion and Disease Prevention in the Elderly, 3 editions of Geriatric Nutrition, a Health Professional's Handbook with a 4th edition anticipated in 2011, and 2 editions of Communicating as Professionals. She has served on the editorial boards of 6 peer-reviewed journals. She has been involved in many other professional activities in the American Dietetic Association of Gerontological Society of America and the National Institute of Aging, the Administration on Aging, DHHS Public Health Service Committees, the Surgeon General's Office, VA Healthcare Reform, Health Resources and Services Administration Bureau of Health Professions, the National Academy of Science Institute on Medicine, and the Center for Medicare and Medicaid Services, to name some. With that said, it is my pleasure to welcome Drs. Judith Howe and Ronnie Chernoff.
Thank you, Faye, very much for that generous introduction of both Dr. Chernoff and myself. This is the second in a 2-part series of the Learning Curve, which is a geriatric professional development webinar series they announced. And in the first presentation, Dr. Chernoff took the lead, and in this presentation, I'm taking the lead, but we both contributed to the content, and we tried to make the content complementary between the 2 webinar presentations. You can see that I had put up a poll ascertaining the professional category of the participants. If everybody who hasn't clicked could click, I see that we have 9 people who've clicked on. In the interest of time, I am going to go ahead and show the poll results. They are there. I thought I was going to get a pie chart. I guess not. And I will keep the polls open and move on to the actual presentation at this point. Okay, hold on a second. A little different. Now, I think many of us have worked on teams, whether they be in a healthcare setting or school-based or many other places that host teams. And sometimes we're just sitting there and we're not really communicating or being a cohesive part of the group. We're thinking, come on already, let's stop this. I heard enough of this already. And what we're going to talk about today is ways to make teams, more cohesive, more productive, and ultimately to benefit the client or the patient, in this case, older veterans. The session objectives for today are to describe variations of interprofessional healthcare teamwork, to use successful team-based solutions to guide team members in meeting the needs of the patient. We're going to talk about the roles of team in the VA PACT model, and finally talk about developing strategies to foster productive collaborations with other team members. I should say at this point that we tried to make this an interactive presentation to some degree. It's not always the easiest in webinars, but I do have a video embedded. I have a handout, and I have 3 more polls. When we get to the video, I'll show you where the handout is. But first, let's review the evidence for teamwork. And I don't have the time in this relatively brief presentation to give you all of the evidence. I really researched this quite a bit in my career, and there is a mounting body of evidence about the effectiveness of teams in many settings, including healthcare. I'm going to just give you a snapshot of a few studies that provide evidence about team effectiveness. Lemieux, Charles, and McGuire several years ago reviewed the team literature over about 20 years, and looking at 36 studies, they found mixed evidence. In fact, most team versus non-team interventions are in our VA system. We do have a long history of teamwork, as we all know. And these studies found that geriatric teams led to higher functional status, better mental health, and decreased dependence and mortality. Another study was conducted by Rubenstein in 2004, and he and his colleagues found that studies of clinical and cost that teams found that patients were helped by an initial assessment by multiple disciplines. And then in the third study that I'm citing, 26 programs for all-inclusive care for the elderly were assessed, and it was found that team performance was significantly associated with better patient outcomes. So they were able to look at the team dose, so to speak, in those 26 different PACE settings and did find better outcomes depending on the effectiveness of the team. There have been several qualitative studies, which I'll refer to now, and they point to the fact that team members really do need to know and trust each other for team effectiveness to occur, for teams to be cohesive. McCallan found in a qualitative study of 44 participants that when interdisciplinary practice is well established, members tend to have a more cooperative attitude and more positive interactions. Similarly, Long, in a qualitative study of team members' understanding of teamwork, found that after a 3-day workshop, the more hierarchical attitudes and lack of role understanding were reduced, that the time spent together in the 3-day workshop helped the participants return to work better prepared and work a more cohesive and effective team. So this webinar is geared to primary care practitioners, and particularly in rural settings. So I wanted to highlight some of the benefits of teamwork in the primary care setting. First and most important, it improves patient care. We have to remember always that the patient is always at the center of the team. Teams can reduce duplication of services, costs, assist in transitions. One important transitional issue is medication reconciliation when patients move from setting to setting. Teams, because of the collaborative nature of successful teamwork, help promote creative solutions to complex problems, which are, of course, more commonly found in older patients. A good team pulls in family and friends and even neighbors into the team, into the collaborative decision-making process in care plan development. Teams can help distribute workload and overburden practices. For instance, I'll talk about the PACT team model a bit later. In that model, the primary care practitioner can rely on other members of the teams and other teams to reduce his or her workload. And finally, teams can enable providers to work at the top of their licenses. This is a key tenet in the PACT teams. As I said, we're going to talk a little bit about that later in the presentation. Now, over the years, there have been a number of definitions of teams that have been bandied about. And again, I don't have the time to get into long discussions about each of these types of teamwork. But, traditionally, the disciplinary team reigned, and that would be, a team of physicians, a team of nurses, and so on. And over the years, we moved to the multidisciplinary and then into the interdisciplinary teams, and now there's a new form of teamwork referred to as transdisciplinary. I'm going to talk a little bit about the differences between multidisciplinary and interdisciplinary teams because I do think that there can be confusion amongst these two types of teams. Often we think we're working interdisciplinarily when in fact we're not. We're really stuck at the multidisciplinary team level. In that type of team, the members work side by side. True collaboration is minimal. There can be layering of chart notes, orders, and meds, so there's an additive effect rather than a true collaborative sharing. Members always within their discipline and not often to the top of their license. So oftentimes the patients and the clients may suffer because there is uncoordinated care that's delivered sequentially or in a layered fashion. When we move a group into the interdisciplinary mode of work, we often see some of these hallmarks. One are common goals and protocols which are agreed upon by the team members. There's shared responsibility in decision-making. There is not an autocratic decision-making modality, but there is true consensus. All disciplines are involved on the consensus, and communication and collaboration is open, it's easy, and it results in positive role overlap and sharing. And at its highest functioning, interdisciplinary teamwork may be considered transdisciplinary. And this is a concept that's come out of nursing and actually child development, where there is team sharing amongst disciplines or provider categories within limitations of scopes of practice. There is a lot of back and forth with these terms. It gets a little muddy. So, not all groups are teams. We all work in groups which are collections of people, which often can be accidental. And so a working group can be dominated by a strong leader who might be somewhat autocratic in his or her style. The main purpose is usually in alignment with the organizational mission within which the team operates. Individual work products are produced, meetings are quick, they're efficient. It's kind of a discuss, decide, delegate operation. So what we want to talk about here is a focus on how we move a working group to a team. And it's really a movement from people working in a parallel fashion to full engagement of all team members. There is a sharing of leadership. There is both individual and mutual accountability. And it does require a commitment from the members to be a collaborative team. And there also needs to be effective leadership. And this ties into Dr. Chernoff's talk of last week, or last month, I should say. Well, that was in March, correct, Ronnie?
It was what?
No, it was April 6th. So it was last.
Oh, it was April.
I have another poll here. For those who participated in Dr. Chernoff's webinar on leadership, you'll remember that she talked about 3 common leadership styles: democratic, authoritarian, and free rein. An authoritarian leader is one who tells his or her team members what they want and how to do it, whereas a democratic leader involves his or her team members in decision-making. The third major category is free rein, and these leaders allow team members to make the decisions. They do not provide any leadership direction. So at this point, I'd be interested in you self-assessing where you feel you fall in these leadership categories. I think this will just make a little more interactive. Is there anything you'd like to say briefly at this point, Ronnie, in a minute or less, while people are still at the polls?
While they're at the polls? No, but one of the points that we made in the last webinar was that a really effective leader uses all 3 styles intermittently, depending on the situation and what will work in for that particular issue or problem. And so it's not unusual for an effective leader to be all of those things, but not at the same time.
Right, although usually we do have a predominant style, wouldn't you say?
Yes, I would, but a really good leader knows when to change that style to fit the situation.
Okay. So, any other votes here? Okay, so we see that at this point, those who choose to vote, almost I think we would want to think that I guess we're democratic in our style and not necessarily authoritarian. And about a third, almost a third, have checked other. That might be an amalgam of those three. I'm not certain about that. We could talk about that later if you would like. So at this point, I'd like to move into some of the key elements that have been identified in building teams in primary care. And these elements are derived from an excellent book, Improving Primary Care, Strategies and Tools for Better Practice, that came out a few years ago. It's written by Bodenheimer and Grumbach. It's very good. I would urge you, if you're interested in this topic, to check this out or to buy it on Amazon. And they identified the need for defined goals, not only an overall organizational mission, but specific measurable operational objectives, because without those, you cannot define success of your teamwork. Systems are important. In the VA, we're lucky to have CPRS. Systems help us track the data, the outcomes, and the effectiveness of our processes. Task definition, division of labor, role assignments, and responsibility is another key component. Excellent training for roles on the team, and also cross-training so that team members can substitute for others in emergent situations or for planned vacations, for instance. And finally, communications protocols and structures. Bodenheimer and Grumbach's model really provides the foundation for PACT training. And I'm going to ask you now, how many of you are familiar with PACT training? And how many, this particular poll asks you how many have participated in the patient-aligned care team PACT training. I'm going to check out yes, and I learned a lot from it. I'm actually a trained faculty member in PACT for VISN 3. And I know that it's being rolled out a little bit differently depending on your VISN throughout the country. And some of you have had it and some of you haven't, but it is a secretary's mandate at this point in VA. Okay, so I see here that we're going to put, it's going up. We don't have everybody doing the poll from the attendees that I see at the top of the screen, but it looks like, a third of you who voted have had PACT training, and 2/3 have not had the PACT training. So I'm going to tie this presentation at this point to the VA PACT model, because it is particularly relevant within the VA. Of course, this is a VA-sponsored webinar. Let me go back to the content here. So in the PACT model, there are seven principles that drive patient-aligned care model, and they're patient-driven, team-based, efficient, comprehensive, I'm just going to read it at this point, continuous, an emphasis on communication, and an emphasis on coordination. Okay, these all make sense, of course. Some of you may have seen this schemata of the PACT teams. You see the primary care team is a large circle. The teamlet is in the middle. The teamlet consists of four individuals with specific position descriptions. The primary care provider, the RN care manager, the clinical associate, who would be a varied background in nursing, and then the clerk. And then the larger or the expanded team is around on the outside, and that includes non-VA care, hospitalists, and specialists, for example, and also you see the family and the community out there linked in as well. So I described the teamlet, which is on the left of this slide. The team, draws on all of the specialty disciplines, mental health, other VA programs, social work is to me, amazingly, not part of the teamlet. As having a social work background, I would have hoped that a social worker would be in the teamlet. For those of you who maybe perhaps work on PAC teams, you know that the teamlets are huddle. That's a new word now. Huddle on a daily basis just to catch up, usually at the beginning of the day, to see what needs to be done. Whereas the larger team, the expanded team, generally has a sit-down weekly meeting. Now, some of you may have participated. It was a very interesting webinar several months ago sponsored by HSR&D, and it talked about the team development measure. And it's something that I have studied a little bit, and I find that I like the approach and the self-assessment. The team development measure is really useful for identifying ways to improve the teamwork. And you can see that the conceptual model is 8 stages, beginning with the pre-team and working all the way up to a fully developed team. So at the bottom, you would have what would be called an accidental team, and then you work through, building cohesiveness, communication, role clarification. And then when all team components are in place, you would have a fully developed team. Here you can't really see the team development measure, but I wanted you to get an idea of the 31 items. In the 31-item scale, each member spends about 10 minutes to complete the questionnaire. And then this leads to a meeting of the group as a whole to discuss strategies for improving team development based on the self-assessment of each team member on these 31 items. Whereas this instrument can be used at any point in the life of the team, it's recommended that it be used in the beginning of team formation to encourage optimal teamwork. At this point, I thought we would mix it up just a little bit, and I'm going to show you a DVD of Mr. Rosario. This was developed in the GIT program, the Geriatric Interdisciplinary Team Training Program, funded by the Hartford Foundation, beginning about 15 years ago. And in this particular video, as it says on the side, 4 members of the healthcare team are assembled for their weekly meeting to discuss this patient. He's an 81-year-old white male with adult-onset diabetes who lives alone. So after viewing the DVD, or I actually should say while viewing the DVD, think about the effectiveness of the team meeting. And so I'd like you to go to up in the corner or up at the top, you'll see a little, like 3 little pages. It says handouts. Okay. This is a handout right here. I have to go to content. It's right here. Okay. So you'll see that the observation tool goes over team goals, professional roles, the organization leadership, cohesion and communication and outcomes. So if you're able to download it, that would be good while you're viewing the video. If not, it's up on the screen right here. So now I'm going to go back. I'm going to play the video for you.
You are about to view a 5-minute video of a simulated team meeting. At the end of the tape, you will have 10 minutes to answer 5 questions. Questions will focus on team members' behaviors and the effectiveness of the team in meeting the patient's needs. Please print your answers and do not use abbreviations. 4 members of the healthcare team are assembled for their weekly 8 a.m. meeting. The purpose of this meeting is to develop a plan of action for the clients discussed. Present in the meeting are Andrea Brown, the social worker, Mary Thomas, the nurse practitioner, Simon Wilson, the pharmacist, and Jennifer Rogers, the internist.
It's 8 a.m. Let's get started. Does everyone have a list of the patients we're reviewing today? Okay, the first one is Henry Rosario. Mary?
Sure. Yeah, Mr. Rosario is an 81-year-old white male with adult-onset diabetes. He lives alone in a two-story walk-up. Now, he's unable to control his blood sugar with diet alone, so he takes tolbutamide, 250 milligrams twice a day. He's been taking his medication as prescribed for the past 6 months. So far, he seems to be in good control. His diet's iffy. He has a sweet tooth, and he lives on junk food, despite my repeated instructions about his need to change his eating habits. His eyesight's been declining over the past year. It'll probably continue to decline, but so far he's able to do things like read his medication label, get his key in the door. Basically, he sees well enough to be safe at this time. He'll be coming in for some routine blood work, and I've scheduled a visit with the podiatrist to look at his feet and cut his nails. Yeah, I'm sure he'll be fine.
Well, why are we discussing this patient if he's stable? I mean, you know, we all have a lot of work to do, and our time is limited. You know, we need to set some ground rules about these meetings if we're going to get anything out of them.
Dr. Rogers, I've listened to your presentations no matter what you choose to focus on. The information I'm presenting is very important. It is exactly what we agreed should be the content of these team meetings. I'm saying he's stable now, but he's likely to be at risk for accidents and hyperglycemia in the future. And since everyone here may see Mr. Rosario over the next few months, I think this presentation is highly relevant.
We're supposed to present cases that seem complicated or require the input of others. Those are the ground rules. Was there something specific about this case you wanted us to review? Should I talk to him about his declining vision or other supports he might need?
Yeah, sure. I'll tell him to contact you when he's here later today.
What about medications? Is there some medications Simon should review?
Yeah, I'm interested in the tolbutamide. Is there anything else he's taking?
He's also taking Tylenol, 650 milligrams for some mild arthritis. And he takes Dalmane, 30 milligrams for sleep. Sometimes he repeats it.
Dalmane? Dalmane is a terrible drug for geriatric patients. He shouldn't be on Dalmane.
Really? Well, he's been on Dalmane for the past 30 years.
He hasn't been a geriatric patient for 30 years,
Well,
has he?
Simon, perhaps you can offer us another suggestion, another medication, a different dosage. You know, sleep problems in the elderly are quite common.
Yes, I know. I'm just surprised you don't know more about sleep medications. I mean, Dalmane can really be a problem because it's got very long half-life, at least 2 days. And this potentiates problems that all the hypnotics bring about, hallucinations, agitation, changes in memory and gait. Now, Benadryl is what I would recommend. Benadryl in small doses, 25 milligrams, can be very effective, doesn't have too many side effects, can be easily. Now, it does have some anticholinergic problems, but we can...
Thanks, Simon. We'll all think very carefully about sleep medications in the future.
Well,
Just trying to...
do we know the history of the sleep problem? I mean, maybe he doesn't need it anymore and he can be tapered off in time. Or perhaps it's sleep apnea that's waking him up?
No, it doesn't sound like sleep apnea to me.
It sounds like you'll work on the sleep problem, but I'm very concerned about his nutrition. It sounds like to me he needs a nutrition consult. I wonder if he can even carry groceries up those 2 flights of stairs.
I've tried to get him to change his eating habits. He's just not compliant. Maybe a nutrition consult will help. Will you go ahead and set it up?
Oh, I have a very busy day today.
Well, so have I.
But if you can't get to it, I guess I can. Anything else about Mr. Rosario?
Nope.
Good. Let's go on to the next patient. Judith Lichtenstein.
you can see from the video that there were, some challenges in the team communication and team cohesion. I think some people aren't muted. If you could perhaps put on your mute, I'm hearing the background noise. I mean, the team did have a goal, and it did have an outcome for Mr. Rosario, but getting there was fraught with, some lack of civility and respect and some behavior that was a bit off-putting. We don't have time to process the observation tool, which I often do in a face-to-face session, but you can do that on your own. So next, I'd like to move on to it's two ladders together, and this has been used in team building exercises in the PAC team sessions. And I like that. It's an interesting team diagram in that it demonstrates the push and pull of effective teams. Because on the ladder on the left, you have relationships. You have the relationship side, so important, civility, psychological safety, all leading up to cohesiveness. And on the right side, you have the functions, the functions of a team where you need to get to go. And this tension between relationships and functions is common and hasn't always been properly addressed in talking about teamwork, in my opinion. And so it will provide the basis for the rest of my presentation. Basically, team challenges and how to deal with them. Now, the first three components, cohesion, communication, and role clarity, are steps in the ladder that I just showed you. Transitions and phases are also two other challenges for teams, and I've identified them as well as areas that I want to briefly address today. In the PACT training that some of you have had and others may have in the future, transitions is a significant topic of discussion. So the first challenge of the five that teams run into is cohesion. Civility, respect, and safety are really building blocks of team cohesion. If the members don't feel safe in the meeting and with their teams, then the teams are going to run into constant trouble, as demonstrated in the Mr. Rosario video. So deciding on ground rules, norms, and protocols, how meetings should be run, are paramount importance. Sometimes teams decide if there's a designated meeting facilitator or coordinator, or if this function should rotate. It just depends on the culture. Ground rules about behavior, cutting off people in discussions, raising voices need to be discussed, all toward the goal of open and balanced